Okay, imagine this. You're trackside, or maybe watching a jumper, and this incredible horse flies past. You hear the power, the hooves, but then, sometimes, there's this other sound.
Yeah.
Kind of a whistle, or maybe a deeper, like, roaring noise.
Mm-hmm. That's the one.
It's not just them being noisy, right? It's often uh, a sign of something specific going on, something affecting their breathing. I find it fascinating, what's really happening with equine laryngeal hemiparesis and hemiplegia.
It really is.
Okay, let's unpack this. So today, yeah, we're doing a deep dive into exactly that. It's often called recurrent laryngeal neuropathy, or RLN, or just, roaring.
Right.
And our mission basically is to sift through all the technical stuff, the clinical reports, the research, and just pull out the essential knowledge. Sort of a shortcut so you can get a really good handle on this condition. And honestly, there are some surprising things in here, along with some really practical insights.
What's fascinating here is how that sound, which seems like a simple symptom, actually points to some really complex biology underneath. It shows you just how fine-tuned that whole respiratory system needs to be for these horses to perform at such a high level, and what happens when, well, even one little part isn't working quite right.
Okay, so let's start with the basics. At its heart, what is roaring?
Well, fundamentally, it's a neuropathy.
Yeah.
So a nerve disease.
Okay.
It affects the recurrent laryngeal nerve, hence the name RLN. And most of the time, like overwhelmingly, it hits the left side of the horse's larynx, their voice box.
And what does that do?
It means the left arytenoid cartilage, that's one of the key structures in the larynx, it doesn't fully open or abduct when the horse breathes in.
So it blocks the airway.
Exactly. It causes an obstruction to airflow.
Okay, maybe we should picture the anatomy a bit more, the larynx.
Right. So the larynx, it sits right at the top of the windpipe, the trachea. Its job is to control airflow into the lungs, obviously, but also, crucially, to slam shut when the horse swallows, so food and water don't go down the wrong way. Inside the larynx, you've got these paired cartilages called the arytenoids. Think of them like saloon doors, maybe?
Oh, yeah.
They have to swing wide open when the horse takes a deep breath in to let as much air through as possible. Then they snap closed for swallowing.
And what makes them open?
Ah, that's the key. There's one specific muscle responsible for pulling those doors open, just one. It's called the cricoretinoideus dorsalis muscle, or CAD muscle for short.
Only one.
Only one. And the nerve that tells that CAD muscle to contract to pull the arytenoid open is the recurrent laryngeal nerve, the RLN.
Okay.
Now, here's where it gets really interesting and kind of weird anatomically. The left recurrent laryngeal nerve takes this incredibly long roundabout route.
How so?
It branches off a main nerve in the neck, dives down into the chest, loops all the way around the main artery leaving the heart, and then travels all the way back up the neck to reach the larynx. The right one just loops around a smaller artery near the shoulder.
Whoa, why would it do that?
It's a quirk of embryonic development, basically. But the result is the left nerve is much, much longer and takes this, well, tortuous path. And that makes it far more prone to damage or degeneration.
So that's why it's almost always the left side.
Exactly. That anatomical journey explains why up to 95% of cases are left-sided hemiplegia or hemiparesis. It's just much more vulnerable.
That is quite a design flaw, isn't it? Almost built-in vulnerability.
You could say that, yeah.
And you mentioned hemiparesis and hemiplegia. What's the difference there?
Good distinction. So think back to those saloon doors. Hemiparesis means the door is weak, it doesn't open all the way, or maybe it flutters or doesn't open quite in sync. There's partial weakness, incomplete movement.
Okay, like it's stuck partway?
Kind of. Whereas hemiplegia means it's completely paralyzed, the
Okay.
door is stuck shut, totally immobile.
Got it. Complete paralysis.
Right. And recurrent laryngeal neuropathy, RLN, is the sort of umbrella term for the disease process itself, that progressive dying back or degeneration of the nerve fibers that leads to the paresis or the plegia, the muscle weakness or paralysis.
Okay, so we've got this nerve damage, the muscle isn't working right, but what's the actual chain reaction inside the horse? How does that translate into the breathing problems and the noise?
Well, when the nerve degenerates, the CAD muscle it supplies starts to waste away. That's
Yeah.
called neurogenic atrophy. The muscle just shrinks because it's not getting the signals.
It makes sense.
Then, during really hard exercise, when the horse is galloping, pulling hard, really sucking in air,
Yeah.
that powerful inward suction, the negative pressure in the airway, actually pulls that weakened or paralyzed arytenoid cartilage
Yeah.
and the vocal fold attached to it into the airway. It gets sucked inwards.
Oh, okay, so it collapses inward.
Exactly. That's what we call dynamic airway collapse.
Mm.
And that physically narrows the opening of the larynx. The proper term is the rheumatoglottis.
Right.
So the space for air to get through is dramatically reduced. Imagine trying to breathe hard through a straw that someone's pinching partway.
Oh, yeah, I can picture that. That's a great analogy. Hard work.
It is. And that narrowing creates significant resistance to airflow when they breathe in. The air becomes turbulent as it rushes through that restricted space, and that's what causes the sound, the whistle or the roar. It's called stridor.
Especially at high speeds, you mentioned.
Yes, because that's when the airflow demand is highest
Yep.
and the negative pressure is strongest, so the collapse is most severe.
And the consequence beyond the noise is they just can't get enough oxygen.
Precisely. Reduced airflow means less oxygen getting to the lungs and blood. This leads to early fatigue, poor performance, basically hitting a wall sooner than they should. Especially critical for horses needing bursts of speed, like racehorses or eventers on cross-country.
Okay, so that's the what. Now, the who. Does this affect all horses equally?
No, definitely not. It's seen worldwide, but it's, interestingly, very rare in ponies.
Really? Ponies escape it.
Mostly, yeah.
Mm-hmm.
The typical patient is a tall male horse.
Ah, specific breeds.
Yes. Thoroughbreds are commonly affected.
Yeah.
Also warm bloods, jumpers, dressage horses, and draft breeds.
Draft breeds, too.
Oh, yes. The prevalence can be quite high in some draft breeds, sometimes cited as high as 40% or even more in certain populations. Whereas in thoroughbreds, it's estimated around 5%, maybe up to 9 or 10% in some studies. It's much less common in standardbreds, the trotters and pacers.
That's a huge difference between drafts and, say, standardbreds. Any idea why?
It strongly suggests the genetic component, possibly linked to height or specific breed conformations. Something about being big seems to predispose them.
And age. Does it show up early?
It typically becomes apparent in young adult horses, usually diagnosed between, say, 3 and 7 years old. In thoroughbreds, studies show the incidence increases a bit with age, maybe 6.5% in 2-year-olds, going up to 9.5% in 6-year-olds.
Okay. And the causes. You said the nerve degenerates, but why?
Well, frustratingly, in the vast majority of cases, especially the common left-sided form in these large breeds, it's idiopathic.
Meaning we don't know the exact cause.
Correct. There's strong evidence for a genetic predisposition, though. It definitely seems to run in families. And taller horses are more at risk. Often you'll see it in offspring of affected stallions.
So genetics plays a big role, even if we don't know the precise why.
Exactly. But there are other, less common causes.
Mm-hmm.
Direct trauma to the neck could damage the nerve.
Like an accident.
Yeah, or sometimes even complications from injections near the jugular vein if they accidentally hit the nerve area, perovascular injections. But problems in the guttural pouches, those air sacs in the horse's head, can sometimes affect the nerve as it passes nearby.
Mm.
Certain toxins can cause it too. Lead poisoning is one. Also, some plant toxicities, like from certain types of peas or vetches, Cicer arietinum, which is chickpeas, and Lathyrus species.
Plants. Wow.
Yeah. And very rarely, it might be linked to other systemic diseases like EPM, equine protozoal myeloencephalitis, or maybe a tumor pressing on the nerve somewhere along its path.
What about both sides being affected? Bilateral paralysis.
That's very rare, thankfully. When it does happen, it's often associated with things like lead poisoning again, or maybe a more widespread neuropathy affecting multiple nerves, not just the RLN.
Okay, so we've got this range of causes, mostly unknown, affecting specific types of horses. How do vets actually figure out definitively that this is the problem? Hearing the noise isn't always enough, I guess.
No, definitely not. The diagnostic process is key. It usually starts with the clinical signs the owner reports.
Like the noise?
Yes, that inspiratory noise, the whistle or roar, especially during hard work. Also, exercise intolerance, the horse just isn't performing as expected. Tires easily.
Mm-hmm.
Sometimes owners might notice the horse's whinny sounds different, kind of hoarse. And in some cases, if the muscle atrophy is significant, you might actually see or feel a flattened area, an indentation, on the left side of their throat latch region, where that CAD muscle should be.
You can actually see the muscle wasting away.
Sometimes, yeah, in more chronic or severe cases. But the first big diagnostic step is usually resting endoscopy, laryngoscopy.
Putting a camera down there?
Exactly. A flexible endoscope goes up the horse's nose, back into the pharynx, so the veterinarian can get a direct look at the larynx and how those arytenoid cartilages are moving while the horse is just standing there breathing normally.
Okay.
And here's a really crucial point for anyone listening. The horse should not be sedated for this exam.
Why not?
Because sedatives, even mild ones, can relax the throat muscles and depress laryngeal function. So a normal horse might look like it has paresis if it's sedated, leading to a misdiagnosis. You need to see its natural function.
Ah, that makes total sense. So what are they looking for?
They're watching the arytenoids, looking for symmetry. Do both sides open equally wide? Do they open and close in sync with breathing? They use a grading system. The Hemiparesis system is the most common one.
How does that work?
It's basically grade 1 to 4. Grade 1 is perfect symmetrical, full opening, looks great.
Okay.
Grade 2 is mostly okay, still symmetrical and synchronous, but maybe the opening isn't quite as full as it could be, or there's a little bit of fluttering sometimes. Still considered pretty normal function for many horses.
Right.
Grade 3 is where you start seeing problems. There's definite asymmetry, the movements aren't synchronized, and the affected side doesn't open fully and might partially collapse inwards during inspiration. This is hemiparesis, the partial paralysis, and it can be quite variable.
In grade 4.
That's complete paralysis, hemiplegia. The affected arytenoid just hangs there, completely immobile, and gets sucked right into the airway when the horse breathes in.
Wow, okay, so that grading at rest is pretty clear.
Yeah.
But you mentioned dynamic collapse earlier. This raises an important question. How do you really know what's happening when the horse is actually working hard? Does the resting exam always tell the whole story?
That's exactly the limitation. Sometimes a horse might look okay, maybe a grade 2 or even a mild grade 3 at rest, but then under the stress of high-speed exercise, that weakened side collapses significantly.
So the resting exam can miss things.
It can underestimate the functional problem, yes. Which is why, for performance horses, the gold standard diagnostic test is dynamic endoscopy.
Doing the scope while they exercise. Precisely. Either on a high-speed treadmill in a clinic or using what's called an overground endoscope, a portable unit the rider wears, or that's attached to the driving harness.
So you can see the larynx while they're galloping or jumping.
Exactly. It allows the vet to directly observe what the arytenoids are doing during maximal breathing effort, right when the problem is likely to be worst. It gives the most accurate picture of the functional impact of the condition.
That sounds pretty definitive. Are there other tests vets might use?
Yeah, there are a few others that can be helpful. Laryngeal ultrasound is one using ultrasound on the outside of the throat latch to look at the CAD muscle itself.
What does that show?
It can assess the muscle's size and its echogenicity, basically, how bright it looks on ultrasound. An atrophied scarred muscle will look smaller and brighter, or more white due to fibrosis. It can be useful for screening or tracking changes.
Okay.
Another thing is measuring arterial blood gases during exercise. We talked about how they can't get enough oxygen. So taking a blood sample during peak exercise can show if the horse is becoming hypoxemic, low oxygen, PaO2 less than 65 millimole Hg, or hypercapnic, retaining too much carbon dioxide, PaO2 greater than 55 millimole Hg. It quantifies the gas exchange problem.
Got it. Quantifying the impact.
Yeah. And of course, it's always important to rule out other things that can cause similar noises or performance issues in the upper airway. Things like arytenoid chondritis, which is inflammation of the cartilage itself, or epiglottic entrapment, or dorsal displacement of the soft palate, the GDSP. So the diagnosis involves fitting all these puzzle pieces together.
Okay, so you've got the diagnosis. You know it's RLN, maybe a grade 3 or 4. What happens next? I mean, can you actually fix it? What are the treatment options?
Yeah, absolutely. There are treatments. The main goal is always to improve the airway, make it wider and more stable so the horse can breathe better, perform better, and hopefully make less noise.
Okay, so what's the first approach?
Well, for really mild cases, maybe a grade 2 or a very mild grade 3, where the horse isn't showing significant performance issues or noise, sometimes the approach is conservative. Just monitor it, maybe manage the horse's workload. No intervention might be needed.
Just wait and see.
Sometimes, yeah. Or, if it's one of those rare cases caused by something specific like lead poisoning, treating the underlying cause might potentially allow the nerve to recover. But honestly, that's uncommon for the typical idiopathic RLN. Nerve damage is often permanent.
Right. So for most performance, horses with significant signs.
For most of them, especially grade 3s and 4s with exercise intolerance, surgery is the primary treatment.
Okay. What kind of surgery?
The most common, and generally considered the most effective for restoring performance, is called prosthetic laryngoplasty. You'll often hear it called tie-back surgery.
Tie-back, right. What does that involve?
Basically, the surgeon places strong, permanent sutures from one cartilage in the larynx to the paralyzed arytenoid cartilage to physically pull it open and hold it there permanently. It's essentially creating a mechanical fix to mimic what the paralyzed CAD muscle can no longer do.
So you're literally tying the airway open on that side.
That's the idea, yes.
Yeah.
Create a permanently wider opening. Now, this procedure is very often combined with another one called ventriculectomy or chordectomy.
What's that?
That involves surgically removing the laryngeal ventricle, which is a little pouch next to the vocal cord, and sometimes the vocal cord itself on the affected side.
Why do that too?
It helps to reduce any residual noise that might come from tissue vibrating in the airflow, even after the tieback. It also seems to help reduce post-operative coughing, which can be a complication.
Ah, okay. So tieback plus maybe removing some extra tissue. What are the downsides or risks?
Well, complications can happen. Chronic coughing is probably the most common one. Maybe 10 to 20% of horses might develop a persistent cough afterwards because the larynx can't close quite as effectively for swallowing. Much more serious, though rare, is aspiration pneumonia. That's when food or water accidentally goes down the windpipe because the larynx isn't protecting the airway perfectly during swallowing anymore. That can be life-threatening.
That sounds serious.
It is. Other potential issues are things like swelling or fluid buildup at the surgery site, called a seroma infection, or failure of the sutures over time.
Okay, so tieback is the main one. Are there other surgical options?
Yes, there are. Another approach which aims for a more physiological fix is called neuromuscular pedicle graft, or reinnervation surgery.
Reinnervation, trying to get the nerve working again.
Sort of. The idea is to take a healthy functioning nerve branch from elsewhere, usually from the first spinal nerve in the neck, along with a small piece of muscle it supplies, and surgically implant that into the paralyzed CAD muscle.
Wow, does that work?
The goal is to provide a new nerve supply to the muscle, hoping it will eventually reinnervate it and restore some active natural movement to the arytenoid. It's generally considered best for younger horses, maybe under 3 years old, who have grade 3 hemiparesis, meaning the muscle still has some potential viability. It's not usually suitable for grade 4s where the muscle is completely atrophied.
What are the pros and cons of that one?
The big potential advantage is restoring more natural function, which might reduce the risk of long-term complications like coughing or aspiration compared to a tieback. The major downside is that it takes a long time, like 6 to 12 months, for the nerve to potentially grow in and start working. And the success rate is quite variable. It doesn't always work reliably.
So it's a longer game with less certainty.
Pretty much, yeah. Then there's another procedure called partial arytenoidectomy, or PA.
What's that?
That involves surgically removing part or all of the paralyzed arytenoid cartilage. It's often used as a salvage procedure if a tieback fails, or sometimes as a primary option.
Removing the cartilage itself.
Yes. But it can lead to significant scarring, which might actually narrow the airway opening later. That's called stenosis. It also carries risks of persistent coughing and aspiration pneumonia. So it's usually not the first choice.
Okay. Any others?
Well, in very severe cases like complete bilateral paralysis, or when other surgeries have failed and the horse really can't breathe, the last resort might be a permanent tracheostomy.
Making a hole in the windpipe.
Yes, creating a permanent opening in the trachea in the neck for the horse to breathe through, bypassing the larynx altogether. But this requires a lot of ongoing management to prevent infection, and it's generally not considered suitable for athletic horses. More for companion animals, just to ensure survival.
Right. And after any of these surgeries, what's the recovery like?
Typically, it involves antibiotics, anti-inflammatories like NSAIDs, several weeks of skull rest, often 6 to 8 weeks, followed by a very gradual return to exercise. They usually need soft feed for a while, and careful monitoring for any signs of complications like coughing or difficulty swallowing. And a follow-up endoscopy, usually about 4 to 6 weeks after surgery, is really important to see how things have healed and assess the outcome.
Okay, so they've had the surgery, gone through recovery. What's the bottom line? What's the actual outlook for a horse that's had treatment for roaring? Can they go back to their job? Does the surgery always work?
That's the big question, isn't it? And the prognosis is, well, it's variable. It really depends on a few key things.
Like what?
The severity of the condition to begin with, was it grade 3 or 4? What's the horse's intended job? Racing demands are very different from, say, dressage or pleasure riding. Which type of surgery was done, and crucially, were there any complications?
Right, like that aspiration pneumonia you mentioned.
Exactly. If a horse develops significant aspiration pneumonia, the prognosis for athletic function, and sometimes even for life, gets much worse. But assuming the surgery goes well, if we connect this to the bigger picture, well, it influences the expectations.
It really does underscore the investment, emotionally and financially, that goes into managing these high-performance animals, doesn't it?
Absolutely. It's a major commitment. So for race horses, The prognosis for returning to their previous level of racing performance is generally considered guarded.
Guarded, why is that?
Even with a successful tieback creating a wider airway, it might not be quite as efficient as a perfectly normal larynx at the extreme oxygen demands of flat-out racing. Some degree of airflow limitation might persist. Reported success rates for racehorses returning to form vary quite a bit, maybe somewhere in the range of 25% up to 70% in different studies.
So a significant number might not get back to their absolute peak.
That's often the reality for racehorses, yes. However, for other sport horses, jumpers, eventers, dressage horses, hunters, the prognosis is generally much better.
Why the difference?
Their maximum oxygen demands, while high, are often not quite as sustained or extreme as a racehorse running flat out. The airway created by surgery is usually sufficient for their needs. Success rates for return to function in these disciplines are often reported as being over 80%.
That's much more encouraging.
It is. And for pleasure horses, trail horses, the prognosis for comfortable breathing and normal, happy activity is usually excellent. The surgery typically resolves the major issue for them.
What about the noise? Does the roaring sound go away completely?
Most surgeries, especially the tieback, significantly reduce or eliminate the noise. That's a major goal. But sometimes a horse might still make a subtle respiratory noise, especially during hard work, even after surgery. That's partly why the ventriculectomy or cordectomy is often done to help minimize any residual sound.
Okay. So improvement is likely, but maybe not always perfection, especially for elite racers.
That's a fair summary. And it's important to remember that even after successful surgery, these horses often require some degree of lifelong management. Careful attention to dust control in their environment, monitoring for any signs of respiratory issues, managing any chronic cough if it develops. It's an ongoing process. #tag outro.
Wow. We've really gone from just hearing that distinctive kind of whirring, roaring sound all the way through the anatomy, the nerve pathways, the tricky diagnostics, and these pretty complex surgical fixes. It's quite a journey into the hidden challenges these horses face.
It really is. It definitely highlights that amazing intersection of advanced veterinary medicine trying to solve problems created by the unique physiology and sometimes maybe even the selective breeding of these incredible athletes.
Yeah, working with and sometimes against their fundamental biology.
Exactly. Constantly pushing the boundaries to help them perform at their best or even just breathe comfortably.
So maybe a final thought for our listeners. What does it really mean for us as owners, riders, vets, or just admirers to understand these kinds of hidden struggles? And looking forward, what sort of innovations might still be out there in this quest to help these horses overcome conditions like RLN?